Good morning to those of you on Pacific and Mountain Time, and good afternoon to those of you on Central and Eastern Time. I would like to welcome everyone to our Executive Educational Series around care coordination. My name is Julie Shills. I am the co-chair within the Patient-Centered Primary Care Collaborative Center for Patient-Centered Medical Home Advancement. I'm also the director for the Patient-Centered Care Transformation Program within WellPoint. Before we get started, I want to remind everyone of our PCPCC Fall Conference. This year, it's being held in Chicago. The title of our conference, and it's really turning out to be an exciting event, is The Journey to Patient-Centered Medical Home, Choose Your Path. It will be held on October 25th, again in Chicago. Normally we meet in Washington, D.C., so we're excited about the new location. You can register online at the PCPCC website, www.pcpcc.net. Today's presentation is entitled The Medical Home Experience, Care Coordination, and the Patient's Role in Shared Decision-Making and Team Communication. Today it is presented by Christine Bechtel, Vice President at the National Partnership for Women and Families, and Melinda Abrams, Vice President at the Commonwealth Fund. Last year, we were very excited. Several co-chairs within our center were involved in a task force that examined the role of care coordination as it relates to the patient-centered medical home. Through the help of Health2 resources, this work resulted in an exciting report sponsored by Fitel and Merck. The report was called Core Values, Community Connections, Care Coordination in the Medical Home. This has become the basis of our webinar series. We have now reached the third in our webinar series, and it is appropriate that we end this series with the foundation that is so important to patient-centered medical home, and that is thinking about the patient's role in the process. Joining us is Christine Bechtel. She is the Vice President of the National Partnership for Women and Families, where she is responsible for the strategic direction and oversight of the organization's day-to-day operations and programs. Prior to joining the National Partnership, Ms. Bechtel was Vice President of the eHealth Initiative, where she headed the organization's membership, public policy, and government relations work. Before EHI, Ms. Bechtel worked with the American Health Quality Association. As Vice President at the Commonwealth Fund, Melinda Abrams directs the Patient-Centered Coordinated Care Programs. She has worked on the Fund's Task Force on Academic Health Centers, Commission on Women's Health, and the Child Development and Prevention Care Programs. She has also played a lead role in the grant awards program to state Medicaid agencies to improve preventative and developmental services for young children. Both Christine and Melinda have served in leadership roles for PCPCC, and we're so excited to have them there to speak to us on this topic. A couple of housekeeping items to cover before we get started. All lines have been placed on mute to prevent any background noise. There will be time at the end of our presentations for Q&A. We'll be monitoring the chat boxes and trying to capture as many questions as we can. So please feel free to submit your questions, and we'll be reviewing those while our speakers are speaking. We also will have polling during our session as well. So there will be some polling questions. They're short questions, but it's an opportunity to have your voice be heard, and we certainly hope that you participate in our polling questions. So with that, I will turn it over to Christine Bechtel. Christine, please continue.
Thanks, Julie, and good morning / afternoon to everybody. I'm happy to be with you today. We'll just make sure we can get these slides to advance. Here we go. I'm going to go ahead and dive right in. For those of you who don't know our organization, we're a nonprofit consumer group. We've been around for 40 years, and we work on issues important to women and families. That includes workplace issues, but it also includes a lot of healthcare issues We have a lot of healthcare initiatives, from health IT to quality measurement to payment reform, access and coverage. One of our major initiatives, though, is the Campaign for Better Care. We are working with more than 150 consumer organizations across the country to engage them in redesigning our healthcare delivery and payment system with a particular focus on meeting the needs of vulnerable older adults who have multiple chronic conditions. And we think about that population in particular really as a litmus test, because if you can make it work for them, you can make it work for anyone. In terms of what we're going to focus on today, we did some work just before we launched the Campaign for Better Care back in 2008 and 2009 with patients and families around the medical home concept. And we did that work because we started to hear some major concerns from the consumer community around what this model is. Is it like HMOs? You know, should we oppose it? A lot of concern and consternation. So we did two things. One was that we convened a set of consumer, national and state and local consumer organizations and patient advocates to talk about what's patient-centered care mean and how could it work in a patient-centered medical home context. And then we also did some messaging research, which included but wasn't limited to medical home. It was really about understanding what patients want from the delivery system and how to talk about those options with them. So I'm going to talk about the part of that research that was related to medical home, and that's actually where I will start today to give you a brief overview there. And then I'll move into looking at what patient-centered care means from a consumer perspective with a major focus on care coordination. And finally, try to take a step back and think about care coordination and how we know if we're getting it right. So in terms of our message research, trying to get my slide. Lauren, my slide's stuck. Oh, got it. In terms of our message research, we did focus groups in a national survey in 2009, and the results of which were published in Health Affairs in May of 2010 in their issue on primary care. We started these focus groups by asking people to share their experiences with the delivery system itself. And what became very clear very quickly was that consumers were experiencing two really central pain points, and they were around care coordination and communication. Over and over, we heard consumers say, look, I just want my doctors to talk to each other. It's that simple. So we presented to these patients and family members and family caregivers a series of options that you can see on the slide and asked them what they thought about health IT, medical home, payment reform, et cetera. And what we heard was actually very interesting. I'll talk about their reaction to medical home in a second. But it turned out that the number one thing that they felt the most sort of appeal with was health IT, which was a big surprise to us. But it made sense in the end because it was the solution that they felt really intuitively they could see how health IT improved care coordination and communication. They did not love payment reform at all, and we can talk about any of this in the Q&A. I won't go into depth. But they were, you know, okay with quality measurement, public reporting, and then patient engagement, you know, they liked, but they felt like things like shared decision-making and giving feedback about their experience with care was a pretty fundamental right. And so it wasn't something that they felt like should be new to them. But in medical home, what we saw was generally very favorable views. It was really sort of the second most highly rated delivery system option that we tested. And again, it was because of that emphasis on care coordination and communication. They really liked the idea of a point person. And I should back up and say, by the way, we described medical home as a medical home base, which was a team approach to providing primary care. We thought we were trying to be clever because we knew that the word medical home was something that does not resonate with consumers. They think it's an institution. So we tried, how about a medical home base? Very clever, absolutely did not work whatsoever. So just nix that one from the vocab. So they really like this idea of a point person to help them navigate the system and coordinate care. They liked the idea of treating the whole person, right? They said again and again, they said, look, I'm so tired of being treated like a collection of diseases and body parts. I want to be understood for, my whole life context that I bring. They did have a lot of concerns, though, particularly around how do you pay for this? Are there going to be new fees associated with it? Who's paying for it? Why would a health plan or an employer pay for it, or the government? They had a lot of concerns around gatekeeping, and that, again, is sort of that throwback to the HMO days. But they were really worried about, well, can I see any doctor I want, or how does this work? So that was of concern to them. They did like, though, that notion of that patient-centered approach, that whole person care. So at this point, I want to dive into talking about patient-centered care by starting with a polling question. And Lauren's going to bring it up. But the question is, how confident are you that you can define the term patient-centered care? So Lauren, take away the little polling function. All right, so everybody go ahead and select your answer and do it quickly because we're not going to have very long, and then we'll share the results. Okay, all right, so what we see is about half of you are confident that you can, which is good. So we're going to, Lauren, get rid of that result, and we're actually going to ask the next question. How confident are you that your colleagues on this webinar would define it the same way that you would? Okay, so the very confidence went down, and the not very's went up, and not at all's went up. So, the point being, of course, that everybody thinks about it differently. It's a little bit of a Rorschach test. And so we have the same reaction, frankly, to it. So let's talk about what patient-centered care is. So everybody has seen the Institute of Medicine definition, which you can read on your screen. I also like the Plaintree definition, and Plaintree is similar, but it talks about planning, delivery, and evaluation of care that is really grounded in partnership between providers and patients and families, and it's about redefining relationships. So these were two that we, many of us have seen and heard before, but frankly, it still left us thinking, yeah, but what does that mean? How do you operationalize it, and what do patients and families think of it? So a couple years ago, we started to convene consumer groups and patient advocates from the state and local level. These are people who work in the healthcare system with patients and families every day, and we wanted to actually explore the medical home concept with them, but you can't really start a conversation with, well, so what do you think about medical home? So what we did was we started by asking them, what do the words patient-centered care mean to you? And what they articulated was pretty profound in its simplicity. They talked about 4 different dimensions of care. One was this, again, notion of whole person care where clinicians really understand all of the factors that affect a patient's ability to follow treatment recommendations, to get well, to get healthy, or to improve their quality of life. And that also those treatment recommendations are made in a way that is in alignment with patients' values and life circumstances and preferences. Right? This group articulated to us, we hear all the time about patients whose doctors will say, well, you got to exercise more. So you got to join a gym. Well, they're low income. They live in an unsafe neighborhood. It's difficult and not probably safe for them to go walking. And so they leave the office thinking, well, great, you're not the first person who said I've had to exercise more. But they're not going to do it because it doesn't really reflect their life circumstances in the way that the recommendation was made. So how do we think instead about, first of all, understanding what are my goals in my life, what's important to me, and how does the treatment recommendation, in this case exercise, really fit in with that and relate to that. And then being able to identify either community resources that I can use or helping me learn how to do home exercises, right? This is much more of a whole person orientation that's really rooted in what's happening in the person's life and who they are. The second domain was care coordination and communication, and I'm going to save that for a second because I'm going to dive a little deeper into that than to the other three domains. The third was patient support and empowerment. This is not about patient education, or I should say it's not just about patient education. This is really about self-efficacy. The belief that I can change, my desire to change, my ability to work in partnership and create shared goals for change and a plan to get there that's backed up by tools and resources. So this is really about expanding my capacity to get well. And then finally, and also importantly, ready access. You can't access the doctor, you don't go. Or if it's not easy, and you don't go. You don't go, you don't get well, or you don't get, or you do get worse, which is, not good. We also heard a lot about even when it's hard to access, the lack of responsiveness, no return phone calls, the importance of having expanded hours. These consumers talked about the fact that they wanted to fit healthcare into their life. And they're tired of having to fit their whole life into healthcare, right, which is how we do it today. So the other thing that they talked about was other kinds of access barriers around language, for example, or physical or cognitive problems being real barriers to access, and it was really important to have a plan for how to address those. So let me dive into the care coordination piece, the domain that they articulated. What they said to us was, again, I want my doctors to talk to each other, and I want them to talk to me too. They like that go-to person who's available to answer questions, have them navigate. They want proactive help choosing specialists and getting timely appointments, right? So this is different than a simple referral. This is, yeah, but how do I build a medical neighborhood where I can actually get some help in getting a timely appointment, ensuring follow-up, from that clinician. They want, complete information at the point of care. They're tired of filling out the same forms over and over again, and I think this is why they really like the idea of health IT. But also, and really critical, the care coordination, making sure that other providers have their information in advance and making sure they have access to information as well. Again, tracking referrals and results, but really helping patients understand the treatment recommendations and the follow-up actions that are needed. And not assuming that, the other care team member who, was interacting explained everything in a way that was understandable or very patient-centered. Providers organize into teams. So this is really an interesting point. What we saw in our research was when we explained why team-based care was important, patients really got it. But what we know from some experience, TransferMed and others I think have experienced this, where if we just move into team-based care, what the experience can be for consumers is that it feels like I never get to see the same doctor, right? And I feel like a cog in the wheel, and I don't even get to see the same people. But when you can help patients and families ahead of time to understand what team-based care means and understand the roles and responsibilities of team members and define their own care team, which is a really critical piece of it because they will define it much broader and everybody will define it differently. It could include physical therapists, pharmacists, dietitians, et cetera. So when they have those understandings and the ability to define their team, that became a really important and attractive element for these consumers. So systems in place to prevent errors and duplication that are, they really recognize the importance of things like what we would call in the professional world medication reconciliation or information exchange and shared medical records. What they talked about, though, and the language that they used was, look, getting my doctors to talk to each other is not just a nicety. It's something, it's the way that you can prevent errors in the system when you've got multiple people involved, and it's the way that you can get to some efficiency in the system to prevent duplication. And so that was a critical piece for them. They also articulated the desire to have help with insurance eligibility, coverage, appeals, or at least referrals for assistance. And I think some will say, well, that might be outside of our scope, but it's, again, reflective of this notion of understanding the whole person that you have in front of you. Connecting to community resources as well. I don't know why we went that direction, but we're going up. So the last thing I want to say is what the underpinning of all of the feedback that we got was this real culture of taking responsibility in a proactive, persistent, and ongoing way for care coordination in a way that aligns the action of care team members with the patient's health goals. That is a very, I think, different kind of approach that the medical home can really help to facilitate. So this is usually the point at which people say, oh my goodness, this is really a tall order, it's too much, these people want everything. And so I think we've got to do some myth busting around a couple key things. And the first is patients always want everything. They want the latest drug, the latest test, the latest treatment. But what the evidence says is that when they are engaged in partnership with their clinicians, through shared decision-making, for example, when they can have that back and forth in partnership, they actually end up making more conservative choices than they otherwise would have. The second myth that we are working to dispel is what patients say they want is like nice and important, but what matters really is clinical outcome. And the point that you're missing if you're in the myth camp there is essentially that these things are exactly what gets to better outcomes. These are what patients have said over and over again. I can get better, I can get healthy, I can maintain my quality of life if I have these things. So these are actually directly linked to outcomes, and I think Melinda's going to do a nice job as well of showing you some of that evidence in her presentation. The third myth, doctors or clinicians know what patients want. But what the research says, some great research by Karen Sapuka and her colleagues, is that when, for example, in her research, doctors are asked, well, what do you think patients want to know about their treatment options when they're diagnosed with breast cancer? The doctor said, well, I think they want to know about the benefits and how do they, sort of get on with life after treatment, et cetera. And when they asked the same patients of those doctors, what do you want to know about your options? The patient said, no, I want to know about the risks. I want to know about the impact, right? So the point here is it's not one party is always right or always wrong. It's that you can't assume that we know what patients want. You got to ask. And then the fourth thing that we hear often is, okay, so if we just do all these things that you said, we'll be good, right? And that's the if we build it, will they come question. And I think that the answer there, especially in a medical home context where consumers already have some hesitance about how this is going to play out, is you can't assume that, right? You've got to build it with them. And in fact, if you build it with them, then they'll already be there, right? So let's jump into a polling question. How would you or how do you know if you're getting care coordination right? Because you implemented some evidence-based practices, or, hey, I got CMS to pay me for it, or I got WellPoint to pay me for it, or because you asked patients and families and they said you were doing okay, or because you worked with patients and families to design and evaluate your process. Lauren with the poll. All right, this is good news, guys. Either you're already doing it or you knew intuitively what the right answer was in terms of this presentation. So 82% said you worked with patients and families to design and evaluate, and that's great. Implementing evidence-based practices, absolutely critical, but doesn't get there by itself without working with patients and families. And asking patients and families for feedback, also really critical, but even better if you work with patients and families. So let's talk for a second about sort of getting care coordination right, which really, I think, has implications for getting the entire model of care right. We think it requires a paradigm shift here to something that we've called collaborative consumer engagement. So the foundation for good care processes that lead to better outcomes is really that notion of partnership. It's how you get to patient-centered care. So the bottom line is this is not how we get patients to do what we want them to do, but it's how we get patients to tell us what they need us to do. So it's definitely a mind shift for some. we need to get it right at every level, right? So there are 3 levels that I'll briefly address. And the first is what a lot of people call patient engagement, engagement in care. That's how we describe patient engagement. So that's the level of a partnership with clinicians to better manage care and improve your health status, but it's based on the patient's own goals. It's going to involve things like shared decision making and care planning. And this is where a lot of people focus today, although what we see is more of a behavior change angle, that, this is, how do we get patients to be better patients? And what we're trying to do is get to the same goal of better health status, right, but in a different way. In our view, patient engagement, or what a lot of people really think of as patient education, has not produced the results that we want on the scale that we want, even though we've been working at it for like a couple of decades. So we've got to shift that idea on its head and collaborate with patients on how to do this better and how to design programs that facilitate their engagement in care. The second level is practice redesign, and that's what I'm going to talk about in a little bit more depth in a second, which is working together, and it sounds like 82% of you are maybe doing some aspects of that, working together to design the care coordination process, evaluate it, implement it, et cetera, designing disease management programs or improving patient experience. Those would be things that you would collaborate to do the redesign with patients and families. And then finally, engagement and governance. So at the practice level, that could be having patients and families involved in hiring staff and setting job descriptions. At an initiative level, if you're a health plan or if you're an employer, having patients and family members and consumer organizations from the community at the table helping you set the qualification criteria or the payment policies so that they're reflective of the kind of care that patients want to receive and the way they want to receive it. Okay, so on that second level of redesign, you guys are familiar with these, so I won't go through every one of them, but this is about, getting patient experience or other feedback data, identifying some challenges, and working with patients and families on quality improvement to solve those challenges. Involving them in staff orientation and training. Of course, creating a patient and family advisory council, doing walkthroughs with them to assess delivery. And Melinda's going to talk as well about some of these. But these are really critical elements of how you know you're going to get care coordination right and, in fact, patient-centered care right in the medical home. So those are, in my mind, must-do, must-have. So that's the key. But what we're not talking about, just to give you a contrast here, is we're not talking about doing things for patients, but not with them. We're not talking about getting people to do what they want them to do without them, right? And we're not even talking about consumer-friendly or patient-focused care, which is more of the provider knows best, we're going to do it for them, and we have the best of intentions, right? But we don't have them at the table. So what we have come to is the model that you see on your screen. This is a model for helping providers do collaborative consumer engagement well, whether you're working on care coordination or any other aspect of the care process. It starts with identifying consumers, patients and family members from your practice who can work with you to partner on these initiatives and giving them then the training and the support that they need to in fact be effective and informed partners. At the same time, it's identifying provider champions who can really help to build the receptivity to this idea of partnership among colleagues and to build the skills for partnering effectively with patients, right? So that means more listening and understanding and collaboration, shared goals-oriented kind of skills. And then the partnership dimension comes in when you actually have consumers in a position of real influence where they can impact the most important care processes that you're designing or redesigning or evaluating, and together developing some shared goals around where you're trying to go and working through collaboratively how you're going to get there. So there's great evidence from the inpatient setting that this leads to better outcomes, lower costs, and very interestingly, much better staff job satisfaction. There's mounting evidence of that in the ambulatory setting and no reason that it doesn't apply. And so the key here is to make sure that our care coordination processes are effective and patient-centered. But what I would submit to you is by following this model, we would actually ensure that consumers help to embrace the concept of patient-centered medical home and actually help it succeed. So, last polling question before I wrap. How likely are you now to partner with patients and families to design or to redesign your care coordination strategies specifically? Okay, about half of you said very, about a quarter said somewhat. I love the hope and prayers. I will keep you in my prayers as well. And, you know, we have 4% who said it's not very likely, and that can be for a variety of reasons. You know, lack of buy-in at the leadership level, lack of understanding sometimes. So I encourage you to learn more. And then, Lauren, you can go ahead and close that out. For those of you who said it's not at all likely, I would just say, here's my contact information. Feel free to reach out. So thank you for listening. And I'm going to go ahead and turn it over to Melinda, who's going to give you some more depth as well.
Great, Christine. Thank you so much. Hi, everyone. I'm Melinda Abrams with the Commonwealth Fund, as Julie said earlier. That was really, I thought that was a really great overview with a lot of practical information. So here I'm going to see if I can now advance the slides. Doesn't look like it. So while Lauren figures out that little snafu, I'm just going to go on to say I'm going to build on what Christine was saying and start a little bit with information. Okay, for some reason I'm not able to advance the slides, guys.
If you just click into the box and take it from Christine, there you go. Perfect.
Oh, excellent. Thanks. So I'm gonna build on where what Christine was saying. Also, kind of do a little bit more on present some of the Commonwealth Fund research, really looking at from the patient's perspective. And then dive a little bit deeper and try to also get at this intersection around care coordination and measurement of how well you're doing with care coordination and the patient and family's role in some of that measurement so that you can see how you're doing and improve your performance. So before we really get into the meat of it, here's my first polling question. And I'm really just trying to get a sense, if you guys had to guess, what % of U.S. adults had experienced a care coordination problem, like experienced a failure, sometime in the past 2 years? Do you think it's 10 to 15, less than 45, most people, or you just have no idea? And this is mostly just, again, because Christine was saying when she keep going, I'm just talking when the results come up. Oh, interesting. Okay. So you guys, a majority of you think that it's 70 to 75%. Actually, our research shows, here you can get out of it, Lauren, and I can, it went too fast. So our research shows that when you stack up a bunch of different kind of problems with care coordination, it's about nearly half, which I still think is rather stunning and astonishing. That's an enormous amount of problems in our system. And as Christine was saying, when they were doing their research and they found that and communication are the two biggest areas, that is very consistent with what we have found through our national surveys. And these could be surveys of public views of all adults. These could be international surveys of sicker adults. I mean, no matter where we look at it, it tends to always come down to problems with communication and problems with coordination. Another way of looking at other problems in coordination is looking at kind of inefficiencies when you feel like multiple tests are being done and ordered, or time that they have to spend on paperwork, and the whole thing is just poorly organized, which in many ways is, again, I think also speaks to my doctors aren't talking to one another. And there it's, again, about a little more than half. And when we talk about, and Christine actually referenced some of this, and so I'm just going to quickly summarize. I know all of you signed up for this webinar because you believe in medical home and you believe in patient-centered care. And I don't think we should do, or let me put it this way. I think it's also important to know and to underscore that by turning care around to revolve around the patient and not around the administrators, the providers, the financing, revolve around the patients and the family, you will get better outcomes, greater efficiency, and I think with that efficiency, you could also begin to see some lower costs. So here's kind of a summary. Those with positive patient experience, in general, are more likely to follow a physician's advice and the medication regimen. And that makes an enormous amount of sense, but it's so important because if you're going to, prescribe some prescription and people aren't going to fill it and then they don't do it, then you feel like, oh, they're not being compliant, when in fact maybe just there was some miscommunication or there are other things going on in their lives that prevent them from actually filling that prescription. You're more likely to be loyal and stay with your practice. You're less likely to file some malpractice complaints. Christine mentioned that there's some decent evidence in on the inpatient, on the hospital side, and that's what this is referencing, is around patients who had a positive experience in the communication and patient-centered care were less likely to have a readmission after acute myocardial infarction. And then also we've supported some research as well that looks at the relationship between patient-centered care and process and chronic disease outcomes, and find overall more likely to see better processes of care in the ambulatory care setting. And then this is information I just wanted to highlight because we funded it, but also because you may not have seen it. It only came out in May, and it really focuses on patient activation. This is work by Judy Hibbert and Justice Green at University of Oregon. Activation is what Christine was talking about with engagement. It's when patients understand their role in the care process and they have the knowledge, the skills, and the confidence to carry out what those processes are. And the research has consistently shown over the years when patients are more activated, they're more likely to engage in preventive behaviors, healthy behaviors, self-management, and information seeking. And in a recent paper that was in JJ, Journal of General Internal Medicine in May, those all, again, showing this link with self-management of hypertension. And we don't need to get into the numbers. It's essentially if you're a level 4, you're more activated. And what you can see here is pretty consistently for patients that report higher levels of activation, they're more likely to take their medication. They're more likely to know what their blood pressure are. They're more likely to monitor. And so they're more likely to feel like partners and take an active role in their care. So again, why the activation is so important and the engagement. And similarly, very, very similar patterns and results around diabetes. I just think this is really exciting and important work, and I really want to draw your attention to it because it's relatively new. So then, as many of you know, this is going more to Commonwealth Fund data. When we have done surveys internationally and we ask patients, and this again is from the patient perspective, creating an indicator of medical home, when patients have a medical home, they are, lo and behold, less likely to report gaps in their coordination of care over the past 2 years. And similarly, they're also more likely to report higher level of patient engagement. I'm not going to go through all of the survey results, but it's really consistent across all of these countries when they say that they have a medical home, and again, it's a composite with multiple questions. There's better communication. There's less likely for errors. There's greater engagement. Less problems with coordination. I mean, it is. If you need evidence to help make a case to your leadership or others in your community, I think some of this might be helpful, and I have other information if you need it. So now I know that this is the third in a series on care coordination, but I just felt the need to put in the definition, and I like this one from ARC, but in part because I wanted to point out that, not only is it this deliberate organization of activities of 2 or more participants, but actually part of the definition is that means, that involves the patient. It's not just, about me. It's not about, you can't do it about me without me, was Don Berwick and a group of people's term many years ago about patient-centered care. And so I just wanted to emphasize that. So now what I'm going to turn to, so we know that care coordination is a core activity of medical home. We know, and we know also that kind of the routine measurement and reporting about the effectiveness and the quality of care coordination is critical. And it's critical if you're going to try to understand if you're actually meeting the needs of the patients and their families. And it can provide very useful feedback either on a discrete quality improvement initiative or kind of on a larger kind of benchmarking overall about how you're doing compared to others across the country. And so before we kind of get into it, I want to just have a quick polling question about how often do you collect and discuss performance data and how well you coordinate your patient's care. No, about how well you coordinate your patient's care. So, we don't really collect and discuss our performance. Well, we collect a lot of data, but we're just so busy, we don't have time to discuss it. We collect and discuss it annually. We do it every couple of months. Actually, we're doing it every day. And so this is not just about the collection. This is collecting and discussing and sharing it. And the winner is, of course, I can't see it. Hold on. Oh, I just lost my. Okay. And the winner is monthly to quarterly. So once again, the PCPCC caters, this is terrific, has got a really great crowd on this, and you guys are definitely, toward the head of the class. I would say on every day, that's really impressive that some of you are doing that, and I think that it's incredibly important. And what I'm going to spend most of my time, for the rest of my time, talking about is some key changes and some key steps that you can consider and that you should consider in setting up a monitoring system to assess the quality of care coordination and really pointing out ways where you can involve patients and families in the process, not just getting feedback from them, but actually also incorporating them into the design and the review process. So the first is, okay. So here are kind of here's the overview of the changes, and I'm just going to talk about quickly talk about each one. So the first, which many of you may be aware of, is kind of the importance of talking to a lot of people, and this it sounds really good, and like of course we want to involve a broad group of stakeholders, but it really is essential. It's essential, and it's essential for multiple reasons. For the participants, whether they're your front office staff, your board of directors, your patients, for them to believe and act on what you collect and what you report. The broad group of stakeholders need to be engaged in the design of the intervention and need to be, and also need to be engaged in the selection of measures used to observe both the positive and the negative effects of what you've designed. And you really do need representation from every step because it's unbelievable, and I'm sure you've all experienced the amount of resistance that you can receive. So you think, well, it's only going to take a few more minutes for someone to go into the chart and pick out those few things. And then, it's like anyone who plays a role in collecting or interpreting or reporting or responding to the data has a stake in how that information is collected and how that information is represented. And, it might be more expedient to hire a consultant to select the latest and most technically sophisticated measures. And, a group consensus process kind of can be, I don't know, take time-consuming, and it might not be really clear where everybody is going to end up. But it ultimately buys everybody in and is really important in the end game, so that the results that you share are both trusted and actionable. So it's not, and then when you're thinking about putting together these groups, of course you should include all the executive leadership and clinical teams and the front office staff, but also I'd encourage you to involve patients and families, because again, it will lead to the buy-in that you need for follow-up action. This is a really important point. Articulate the purpose of your data collection efforts. And I can't actually overemphasize this, because this is something that I run into a lot. So measures for quality improvement and the process for what you're doing for quality are very different than if you're doing it for kind of benchmarking or for evaluation. So the goal of in a quality improvement area is to test or to tweak some piece of your medical home program. The target audience tends to be the champions, the team, kind of the leadership at a site. A hallmark of quality improvement measurement is frequency. Doing kind of plan, do, study, act, doing it really quickly. And while we say, while using nationally endorsed or recognized measures is always desirable, it's not always feasible. Sometimes they're not granular enough. And to be honest, in a quality improvement environment where kind of doing it on a regular basis about kind of some specific piece around some new communication technique that you're implementing, or kind of the office flow on tracking and referrals and whatnot, and involving patients or the emergency department across town, you can modify a measure for a quality improvement, but with it comes a trade-off, and that is a lack of comparability. But if you're clear about why you're collecting the data and why you're sharing it and what it is, and if it's really more about, well, there are no other measures that exist, and really for what we're trying to accomplish, we're going to do this, and that's fine. But just know what that trade-off is. The second category is around accountability and benchmarking, and here, this audience tends to be kind of more of a national organization or your local payer. So, for many primary care practices, one objective of assessing kind of the quality of care coordination is to, earn medical home recognition or earn some kind of pay-for-performance bonus. And so that, you're going to collect this, share it with NCQA or Bridges to Excellence or Medicaid, which can use it to decide whether or not you're meeting this external criteria. And while these measurement programs often have some flexibility built into them, such as kind of the range of measures from which to choose, the menu tends to be somewhat limited, and the measures are predetermined, and because the comparability across sites is so critical. However, and the downside here is that information tends to be collected and reported only once a year, and that falls far short of routine reporting and kind of the routine reporting that you want in a quality improvement environment. The third area is around evaluation, and I have some experience with this because the Commonwealth Fund is supporting about at least like 10 evaluations in medical home demonstrations, and a lot of them have, so there are a lot of, demonstrations and programs, and a number of people have external evaluators, so they're doing internal evaluations, and everybody, wants their work to be evaluated, and I fully support that. But, the truth is that participating in an evaluation often carries additional responsibilities and some constraints for the primary care organization, and the rigor required often increases the administrative burden on the practice. And it's just the truth. And so my point really is, it's not to say don't participate in an evaluation. My point is pull together your broad stakeholder group and be honest about the trade-offs of different measurement activities and what comes with them. And the significant advantage of participating in an external evaluation is that the target audience is often like kind of key payers and employers and families and policymakers who have substantial influence over the program's future. But I think that you really also kind of have to be clear all the way through the organization that it's not always easy. Okay, enough of that. So here again, the value and importance of using standardized nationally endorsed measures, and this is so important to enable fair comparisons, not just between, not just on different aspects of care coordination, but also between how you're doing and others are doing, either in your region or across the country. Using nationally or endorsed or recognized measures, saves time instead of trying to create new ones. The truth where we are in the field is there just is no shortage of measures where there's not a lot of consistency as which ones to use exactly. But the selection of measures, matters. And I know that sounds obvious, but the results that you collect really need to be aligned with your objectives and the intervention that you're testing. And so we're on to the next polling question. How do you know if your patients think you're doing a good job coordinating their care? And so there are lots of options here on which are, well, we survey them, or we hold focus groups, or we just know because they complain. And believe me, I know when my patients are unhappy. Or we have a suggestion box, or we don't know. And the winner is we survey our patients. Excellent. Now I want follow-up questions, but I don't have time for that. But that's terrific. But I will say that it's also only one way, and I would encourage, people to also think that these are not mutually exclusive, and that part of also, that the value of putting together a patient family advisory council is another really important strategy for getting input about the quality of care you provide, all the changes that you're making, but also care coordination. And so that really gets into the next point, which is the importance of collecting feedback from patients, and that really, you can't call yourself a medical home unless you are actively engaging your patients, and part of that engagement includes getting feedback to evaluate their experience. A little bit of a word about surveys. Some of you may, since so many of you are surveying your patients, you may know all of this, but in the past 10 years, the science and the method of assessing patients' experience in surveys has advanced tremendously. The United States Agency for Healthcare Research and Quality, AHRQ, has released a new patient survey that is called that is a medical home CAHPS, a consumer assessment of health system survey. And the instrument builds on kind of the core clinician groups, patient experience surveys, but adds key domains that are aligned with medical home, such as including care coordination. And specifically, the survey assesses care provided outside of the primary care practice, as well as asks about care provided by the entire team and not just the physician. And I think that having, thinking about using that survey might be something you'd consider if you're not using that one already. One quick note, I think some of you may know this, I don't know how many of you are kind of doing NCQA, but NCQA has also added this, this program. You can receive distinction as a primary care practice for collecting and reporting the medical home CAP to NCQA. You should know the results are not publicly reported, but there is this effort in terms of the kind of the standards to move away, to include also the patient voice into the recognition program. And at the moment, it's distinction, but still at least it's there, and we're moving in the right direction. And then, while patient surveys, are a systematic and reliable way of obtaining feedback, they are by no means the only method to do so. And that was why I was also talking about, the number of other options, such as focus groups, in-depth open interviews, comment cards, practice walkthroughs with patients, patient and family advisory councils, and which can provide this check-in on a new initiative, as well as a forum for brainstorming new ideas. So it's not just like, okay, so what do you think, but like kind of trying to elicit new ideas from patients and families.
Welcome to GoToWebinar, Web Events Made Easy.
On recruiting patients does require, for those of you who have done this, does require a fair bit of like planning and skill and ongoing management. It's not necessarily kind of as easy to do as it sounds. And there are some folks who've really kind of put together some useful tips on how to engage patients in quality improvement activities. ARC produced a paper that was released in June 2010 that you may want to look at. So moving on to number 5, which is no. Somebody else? Okay. Developing a tracking system that monitors performance. So, to effectively coordinate care for your patients, the medical home needs to implement protocols that, systematize their referrals, that systematize the consultations and the feedback and the transition and the co-management. And this, requires setting up systems, drafting procedures, and using IT to help reduce kind of some of the ambiguity that can happen about who is responsible for which task. So you need the information, and it's not just about, well, how do I share information between this practice or this provider and the other practice or the emergency department or the specialist or the physical therapist, but also kind of coming up with procedures and policies and expectations about how we also share information with patients and families. And again, then testing it, measuring it, going back to your stakeholder group or your parent advisory council. So it's another just important piece. So information technology can help facilitate some of this. Another tactic or strategy that some places have used is what's called care coordination agreements, which are written documents, that outline the expectations and responsibilities between two providers to facilitate coordination in patient care. My primary care practice, when I signed up, there was actually kind of a participation agreement, but in some ways, where they sent me kind of like the rules of the road with that practice and like what the expectations were for me in terms of scheduling appointments, canceling appointments, and I had to, they sent it to me in an email as a PDF, and I had to fill it out, and then there was someone there available to talk to me about it, and then I had to sign it. So, I think the idea is also to just kind of be really clear about how you share information and routinize it so that it becomes part of everyday work. But what makes the measurement and your assessment of care coordination, work is not the quality of the measures or the technical system that you could set up to make the transfer of information work. What makes it really work is the relationships, and so it's hard. It's hard to always have kind of the information you need at your primary care site, for example, either from another provider where the patient's been to multiple providers. But if you have good relationships, not only with with those providers, and you've set up systems for sharing the information, but also you've just kind of made it clear as well to the patient family, look, this is how we're going to work, this is what we're going to try to do, here's how you can help us out. And so building and maintaining the good relationships is really critical, and using your ongoing use of the broad stakeholder group, to review the performance data can also help foster kind of that community of continuous quality improvement. And then, so it's not, the measures, will not drive the change, but actually, how you use the information and the data is what will drive the change. And so this is, kind of how this is a picture of a measurement wall at Community Health Partners, which is a community health center in Montana. And you can see where, they've got all these run charts and other things, and they've got it in kind of a public space so that also patient, it's in a hallway so that patients and families can see it. It's not hidden, and it allows for, it also just kind of sends a message to the patients about their culture. And so a few tips for data reporting and to drive the quality improvement is making, and again, it's kind of, a lot of these themes seem somewhat repetitive. It's making sure that every staff member understands what the measures are for success. And it's not just, I guess, also the staff, but also kind of making sure that all of your partners, including the patients and families, make sure that you collect stories from patients, make sure you review the aims of your medical home with your patients and their families, whether it's at the time of enrollment or periodically throughout the year as they come in. And review your progress with your advisory council, with your leadership, with your board of directors if you have one, and at team meetings. And then, as I did in Montana, select a visible or an easily accessible location for data reports and make sure that you update it often. So the final polling question is, any of these key changes discussed today, which of them would you maybe try to implement, or if you are already implementing, which one might you try to improve in the next couple of months? Whether it's the stakeholder group, clarity of purpose on what you're doing, incorporating patient family feedback, doing a better job of that, developing a system, or improving how you display and share the results. Drum roll, please. And the answer is, people are going to try to work harder on incorporating patient and family feedback. Terrific. And, I think that there are other resources if you're interested in doing this. I would also draw your attention to some implementation guides that have been created by Qualis Health and the McCall Institute for Healthcare Innovation, part of the Safety Net Medical Home Initiative. And I can, if you have any questions about that or other resources, you should also feel free to reach out to me. I am humbled by the ability to work with such great people across the country, and as you can see, this is very much a team effort. And so this is just a list of a number of my colleagues, both at the fund and across the country. And finally, there are also various resources in trying to select measures for care coordination, and I've listed some of them here. So thank you very much, and I'm going to pass it over to Julie to moderate Q&A. Thanks.
Thanks to both Christine and Melinda for these presentations. I've been monitoring the questions that have been coming through. And Melinda, I think while I'm organizing some of these questions, we have had several questions, and maybe if you can just reflect back on the part of your conversation where you talked about NCQA's PCMH 2011, the optional recognition program, and then maybe speak to a little bit, people had questions about the PCMH CAPS survey as well.
Okay, so I hope I get this right, so I'll tell you what I know, and I'm happy to follow up as well. So what NCQA, so the new medical home CAPS, which really builds on the core clinician group CAPS, but added sections around care coordination and patient self-management, and really to kind of be more aligned with medical home. So it's available, the survey itself is available on AHRQ's website, on the AHRQ CAPS website, and I can send the website to the PCPCC who can send it out to everybody following this call. So the survey is publicly available, and that was released earlier this year. What NCQA is in the process of putting together, and I believe they've actually already done so, is that it's not a separate recognition. What they're calling it is distinction, and it can be coupled with existing or other recognition program. So you can get distinction in patient experience. So there are two things to know here. As part of the NCQA medical home standards, there is a standard that is about kind of obtaining feedback from patients. And one of the options of that is, there are a number of options. You could be doing focus groups and comment cards, whatever, but you could also be doing surveys. If you use and you don't have to use the medical home caps. You can use another survey. However, if you use the medical home caps and follow the recommended guidelines for survey administration, and show all of that to NCQA that you followed the protocol for sampling and you followed the protocol for data collection, and you report it to NCQA, you can, in addition to medical home or in addition to actually some of the other recognition programs, you can then achieve or receive distinction in patient experience. It is a first step or a baby step towards really trying to get the patient feedback into the standards. The results of what the patients say, so whether or not they said they had great access or they didn't have great access, it doesn't matter. It's whether or not you actually are collecting it in a systematic way. Later, I think in the future, it'll be more about like how well your patients rate you, and then later in the future, it'll actually, instead of being optional, I think maybe one day will actually become part of the standards. But I don't really know. I have no inside information. I'm just saying that, that's Christine and I have been working for some time on kind of making sure that all the measures and the standards really reflect patients and families and involve them and their needs. So that's just one piece. Is that helpful, Julie?
It is, and I think someone was kind enough in our question box to submit some links for the audience as well. So those are available to everyone. Thanks so much, Melinda. When both of you were speaking, I did send out a question to the audience asking about best practice. And before I ask a question of each of you, I want to share a best practice that came in from Jamie. And she talks about, one of the things that they do is monitor the referrals that have been initiated and do a follow-up to see whether the patients have been successful in following through on that shared care plan that was developed, and when they get a consult note back or there's some type of information that comes back and suggests there's been that follow-up, and then they know that that loop has been closed. When they can see in the data that services aren't pursued, they follow up with their patients just to find out, what's going on. What are the barriers preventing them, the patient, from seeking care. So I thought that was a wonderful, wonderful best practice that was shared with the group. One of the questions I thought was very interesting and a little bit thought-provoking, and it came early on in our presentation, and it was, and I'm going to, Christine and then Melinda. The question is, do you believe there are any differences between nonprofit or for-profit organizations in the successful practice of supporting care coordination?
Wow. It's Christine. I mean, that's a great question that I don't think I know the answer to. What I look for from a consumer perspective has a lot less to do with profit status and more to do with the degree to which you collaborated with patients and families to design, implement, and evaluate your care processes, and then what your patients are telling you about how well you coordinate care. And also the resources that you offer them, like online access to their own health information in a way that they could download, for example, is a great facilitator of care coordination, whether you're a meaningful user of health IT. So I don't know how to answer that except to say those are my criteria. And if those elements are more or less present in one given kind of profit status, then so be it. But hopefully they are able to be equally present in both. Melinda?
I don't think we know the answer. But I also, I'm not entirely sure if the question is being asked about kind of the difference between nonprofit and for-profit providers. kind of like, your independent community practice that is, a small for-profit business compared to, a community health center, which, and there, I don't think it would be about profit status, one, because I'm not so entirely sure how profitable the primary care, sites are in the first place, but also because I think, I just don't, I'd be hard-pressed to say that there was a difference there. If it was asking about kind of difference in kind of helping to support and coordinate care coordination between for-profit and nonprofit health plans, I'm not 100% sure actually. There's been some data on looking at profit and for-profit and nonprofit plans, but not really about care coordination. And so I would say that we don't know the answer, and I would think at the practice level in the community, I'd be hard pressed to find a systematic difference.
Thanks to both of you. I did think that was a very thought-provoking question, and I appreciate the audience sending that in. We do have some NCQA staff who are participating in our program, and they just wanted to make sure we clarified that the CAPS PCMH is the tool that must be used in order to receive the NCQA distinction. So wanted to close the loop on that conversation.
Thank you, NCQA. Sorry if I was unclear.
And NCQA is, you can go to their website, and they always are very gracious about answering questions. So if you have any other further questions, please feel free to do that. I have always found them to be very helpful whenever I've had any questions. Another question that's come through the chat is really around the staff who are in the practices who might serve as a care coordinator in the practice, and the question really reflects I'm going to give this to both of you again. When selecting someone for the role of care coordinator, do you feel that it's more important to get the right person and the right fit, or to find someone who has a clinical background or clinical education?
Well, it's Christine. I took a shot at answering it online, but I don't think I sent my answer to everybody. I would say that at least from a consumer perspective, what we're looking for is somebody who can really navigate the system, and that requires somebody who knows the system, and that may not be from a clinical perspective, but also whose primary skill, frankly, is relationship building, because that's how you're able to get other members of the care team to respond effectively and promptly to you, and to be able to develop a network of collaborators. I think, Melinda talked about sort of developing partnerships with external stakeholders and clinicians, to effectively facilitate that. Because remember that for our consumers, care coordination doesn't stop at the walls of the medical office, or even at the walls of the other medical offices, or let's say specialists who might be involved. I mean, what consumers, I think, are most helped by, and what supports them most in improving their own health outcomes, is not just the coordination between the medical care professionals, but also coordinating with community resources. So I think it has to be, I think it's great if it's a person who has an understanding of the healthcare system, but is a relationship builder that's going to work with patients and families in a collaborative and productive way, but also be able to really work effectively with other medical professionals and community professionals, and that is an important skill.
This is Melinda. I completely agree with that. I think, and I think I also would make a distinction between kind of someone who's in charge of care coordination for a panel of the patients, and someone who is put in a position where they're doing kind of intense care management for a very high-risk subset of the population of patients. So I think first, the relationship building skills is incredibly important, and I think for a majority of the panel, or whether it's kind of on the preventive care and all these, or or for a kind of a short-term episode or whatnot, really, I think that there's models all over the country where sometimes they're that don't have clinical training and at all. I think when you start moving into kind of the care management for the very fragile or high risk patient, that's where, depending on the roles and the responsibilities, where it's not just care coordination, but also kind of the monitoring of the progression of disease, then I think sometimes you find you're more likely to see someone with clinical training, such as like a nurse care manager. But I think there's a variety of models, and I do think I would find someone who's better at kind of relationships and communication and knows the community over making sure that you definitely had an RN.
Thank you. Another question, and this is an ask from Wendy, and she's asking, and I would challenge those of you who are participating in the call, if you have any thoughts about this, please put it into the chat room and share your experiences. But the question is, please share pointer suggestions for selecting a patient and family participants for a patient council. Wendy happens to work with more than 50% Medicaid, Medicare population, and many are uninsured and underinsured patients. I know that there's been some really wonderful work from the Institute for Patient and Family-Centered Care. Christine, I think I'll ask you to perhaps answer this question and again challenge our audience to share their perspectives as well.
Sure, thanks. So I think we've actually developed a list of characteristics, so anybody who wants to can reach out to me, and I'll send it. I would say, first and foremost, if you're going to work with patients and families, they need to be somebody who has experience in your practice and who, is able to bring that experience in a way that demonstrates that they're really invested in making the practice operate more positively. And that doesn't mean that you're looking for somebody who has only had a negative experience or who has only had a positive experience. You need both, and you need to learn from both. I think the second thing that's very important is someone who can share their experience and their ideas in a way that can be heard effectively by others. So if you have if you can tell your story, and in fact storytelling itself is a very effective learning method, so being able to really engage with others in a way that they can hear is important. I don't think you need somebody who knows the ins and outs of the healthcare system. I think they need to understand their experience, and they need to be willing to partner and willing to learn. And more importantly, though, they also, in return, need to see the evidence of the impact that they're having. So if you have a patient and family advisory council, and a lot of people do, and it meets once or twice a year, or even 3 times a year, and you take their feedback and their ideas and you go away and you may implement and you may not, but you just have the next meeting several months later and they don't know really what happened, that's not a very fulfilling experience. And so getting beyond that mode where you have an advisory council that is much more active, dynamic, and integrated, giving feedback in real time, learning why something did or didn't work or why the practice decided that we're not going to implement that idea, really being part of the solution. That's the nature of partnership. So I think you want to have also a wide range of perspectives as advisors. So you want to have a family caregiver, for example. You want to have people with chronic conditions. You want to have people who are healthy too, right? I mean, I can tell you that from my experience, I would pay money to be on the advisory council for my physician because they are a level 3 qualified medical home, and they're absolutely awful. And I keep talking to them and asking them, I would love to help, and they don't really want to have anything to do with that. But nonetheless, so I think having that range of young, old, healthy, et cetera, chronically ill, experienced healthcare users is really important, with the underlying idea that you've got people who can share their story in a way that can be heard and understood, and that they're really invested and want to help make the practice better.
I think she covered everything.
And Christine,
I don't know that I have anything to add.
Christine, is this information, you mentioned outreach to you, but by chance is it on the National Partnerships website or available there, or we can follow up and make it available on the PCPCC website as well?
Yeah, I think that's probably the better way to go,
Okay.
is to make it available on the PCPCC website. A version of it is for a particular audience, but I think it's probably better for us to generalize it and get that to you.
And then there is a checklist for getting started that was, kind of, if you want to put together a patient and family advisory council, the Institute for Family-Centered Care, which is based out of Bethesda, Maryland, has developed a checklist, and that's available kind of, on their website, but we could also probably talk to them and get a link from the PCPCC website.
Yeah, and that is the Institute for Patient and Family-Centered Care. For any of you who are really interested in taking your collaborative consumer engagement to the next level, that's a great resource, and they do a lot of work training providers and have a great network of patients who are involved with medical homes, and some of their profiles are on the Institute's website.
And I'll add a personal story to the conversation. I had an opportunity to be in York, Pennsylvania with the Aligning Forces for Quality group, a group of practices who are working on patient-centered medical home organized around the community, doing wonderful work, and they have patients as partners in their quality improvement activities, and had been focusing on diabetes, and they had a learning collaborative, and I was honored to be able to participate in that, and really to hear the patients stand up and talk what it's meant for them to be a part of the panel was so inspiring. At first, a lot of them, shared similar stories that, I thought, what the heck do you want me to do? But then they realized, one patient mentioned, the practice really wanted to do these wild, what I thought were wild and crazy things, and I thought, it's just really a simple fix, and if you do this over here, then these 25 steps that you think might solve the problem, really, that's all we're asking for. The other thing that came out of it is all of the patients had diabetes, and one of the things they really discovered in the process for themselves is how much they need to own their own health and how they do need to be an active participant. So it's just incredibly inspiring to hear all of those stories. We're wrapping up at the end of the time, and I'm looking at all the questions, and unfortunately, I think what I'll do is just, if there's any reflections or any parting words, Christine or Melinda, that you would want to leave with the audience. I thank both of you so much for your time, your energy, your support around this topic. It's certainly helped support us all being much more successful in not only being patient-centered in our approach, but also the topic of care coordination. So with that, any last words from either one of you?
Well, Christine, I would just say thank you very much for joining us, and I thought this was a terrific discussion. I read through a lot of the questions online and attempted to answer a number of them that I could. It's just great to talk to a group that's very engaged in this and committed. So if we can be of help to you, please let us know. Thank you.
And thank you for inviting me to participate. And if there are, follow-on questions, if you direct them to the PCPCC, I think they're probably the best hub for kind of then sharing them with everyone else, or feel free to reach out to me directly. I guess two parting things, just kind of in light of some of the questions. I will say I think there are, in addition, of course, to the National Partnerships website and resources and Commonwealth Fund website and resources, I think there are two other sites that you may want to check into that you're probably aware of, because it seems to be a kind of a more, I don't know, kind of a very educated crowd. But one is the ARC Medical Home site, which is, I just looked it up and now I've forgotten it, but it's like medicalhome.arc.gov, something like that. I'm sorry, pcmh.arc.gov. And then the other one that I'd highly recommend is safetynetmedicalhome.org, which is another place that has a lot of implementation-oriented guides on a whole range of issues for transforming your practice into a patient-centered medical home. And of course, want to thank the PCPCC and Julie, you as moderator, and everyone else who put this together.
Well, thanks so much to both of you. Many questions in our question box around having the presentation and the recording available. They will be available on the PCPCC website. That is www.pcpcc.net. There is a section on the PCPCC website that talks about presentations and recordings, so you can see where these are at. And if you put in the words care coordination, that will take you to some of the documents that have been developed historically with multiple stakeholders on behalf of the PCPCC. So that's another opportunity as well. And with that, thank everyone for their participation and wish you the most success in terms of how you can take some of what we've heard today and really have the what can you do by next Tuesday attitude of implementing something within your organization.
Thank you.
Thank you.